Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen, distinguished guests, and esteemed speaker. It is my honor to welcome all to the Kuwait Annual Radiology Conference. We have gathered here to exchange knowledge and innovations which shape our field. My name is Abdullah Abujamea, and I am delighted to serve as your moderator for this session with my colleague Ahmed Nasser. We have an exciting lineup of speakers and panelists who will be sharing their expertise on the radiology field. This conference is not just about listening, it's about engaging and questioning meaningful conversation. Before we begin, I would like to go over a few important points. Please ensure your mobile phones are on silent. There will be a dedicated question and answer session after each presentation. So feel free to note down your question. Now, without further delay, let's begin our first session. It is my pleasure to introduce our first speaker, Dr. Abdullah Abujamea, Associate Professor and Consultant at the Department of Radiology and Medical Imaging, College of Medicine, King Saud University. He has a PhD in the Medical Physics and of MRI from University of Nottingham. Let's give them a warm welcome.
السلام عليكم ورحمة الله. سعيد جدا اليوم أن أكون معكم، وأحب أني أشكر على حسن الاستضافة وحفاوة الاستقبال. هذا تطبعكم وهذا في البلد الثانية. أشكركم على التنظيم وعلى الاستضافة. بدون تأخير حتى السيشن الأول اليوم. حيكون شوي فيه little bit physics، فحيكون شوية دسم، لكن إن شاء الله نحاول إنه من خلال نسهل الموضوع بأقصى ما نستطيع. So first of all, we will start with historical background of MRI. Nowadays, MRI become as a standard diagnostic modality in most of the hospitals. I'll try to make my speech in English and Arabic so it can be more excited. So. MRI first was introduced in 1945, where it was called NMR, nuclear magnetic resonance, and it was introduced by two scientists, which is called Bloch and Purcell. In 1973, the development of NMR as a diagnostic medical imaging by two scientists, Peter Mansfield and in Nottingham University, and Luther Bohr in New York. I was honored to be a student of Peter Mansfield. I graduated from Nottingham University, where he was one of my tutors. Both of them, they granted Nobel Prize in 2003 for the Nobel pioneer of MRI. In 1976, again, Peter Mansfield was able to publish the first MR image for his finger, and in 1977, the first whole-body MR image was introduced, and it was a cross-section through abdomen and heart. The image at that time was not really very impressive, but it was like a cornerstone for the MRI development. And this is the scanner where they first started MRI. This image took 4 hours to acquire. So imagine that the volunteer was in the magnet for 4 hours. Again, this is just a quick video for Peter Mansfield, who was interviewed in 1978 with the BBC, and he was just describing what they did in MR. So he was just trying to demonstrate with the small magnet that they built in the university, in Nottingham University, and he said that time we don't know what we are heading to. So he said maybe there will be like a side effect of the of the scan. There is a sound, but I don't know, maybe it's not, he's talking, I mean, describing, yeah.
In new experiments of this type, one can never be 100% sure that there won't be any adverse effects. The worst thing that could have happened would be a cardiac arrest, so that when the button was pressed, I would have either had an immediate cardiac arrest. If that didn't happen, then I was fairly certain that things were okay.
Yeah, that's fine.
Now are you ready to go?
Yes, I'm ready to start.
Fine, okay, then press the switch and let's go.
Okay.
This is the computer they were using.
Dr. Mansfield feels nothing. The machine consists of 4 large electromagnets. They produce a huge magnetic field which passes right through the body. At the target area, there's a smaller, separate magnetic field which is used as a 3-dimensional.
So that was the huge magnet, which is like 0.001, which is at that time it was a huge magnet. For today, this is called a very, very low magnet. Today we have huge magnets, really huge magnets. We can reach up to like 7 Tesla as we will go through the session. So since the development of MR imaging technique has been also rapidly developed with the computer science, also with the computer technology, nowadays we can see the real hard beating and a scan of the brain functions. So we will just go quickly through theory of MRI. As we all know, the source of the MR is a spinning motion of a specific kind of nuclei. They called MR protons, MR active nuclei. As we can see, the nucleus itself is orbiting about its own axis, and also the electron is spinning around the nucleus. Our MR signal is generated through those protons, which is in the nucleus. So MR-active nuclei, they're characterized by their tendency to align their axis of rotation with the applied field. So it means that those kind of protons, when you put them inside a strong magnetic field, they will align with that magnetic field. Not all nuclei, they have this tendency, but some of them, which we call them MR-active nuclei, and hydrogen is one of the most common example of those. So the hydrogen is the most active nuclei used in medical imaging because it is available in our body, it's abundant in our body also. Because it has a single proton, this makes it very sensitive to the magnetic field. And that's, we call it, so it will act as a small magnet. This is an example of some MR nuclei which can be used to generate MR signal. It's like hydrogen, carbon, nitrogen, oxygen. All of these nuclei can produce MR signal. But in medical imaging, we concentrate on hydrogen because, as I said, it is very abundant in our body, and also it has a very high sensitivity. It's easy to some extent to get the signal from hydrogen. So to get the signal from hydrogen, we have to put the protons in a strong magnetic field. So this means that we have to generate a strong magnetic field that the patient should be inside that field to make the protons aligned with the magnet, either parallel or anti-parallel. So once the protons are inside the magnetic field, they will start to process about the magnet. They will start to spin about the magnetic field. And so we will have additional spinning or wobble. So first, it was spinning about its own axis. And then once we put it inside the magnetic field, it would have additional spin, which is about the main magnetic field. So Larmor, he discovered this, and he discovered also that the strength of the magnetic field will make the protons spin faster. So he stated that as the frequency or the spinning of the protons is proportionally to the strength of the magnetic field, and to make it an equation, we put that constant which depends on the nuclei. For example, hydrogen will spin different or in different speed of let's say in physics we say frequency, not speed, to be more accurate. It's different frequency than carbon or sodium. So it depends on the kind or type of the nuclei we are going to use. So as you can see, this is the proton or the hydrogen proton. And once we put it inside the magnetic field, it will start rotate about the magnetic field. Now, having this we will not benefit from it. يعني إحنا ما راح نستفيد unless we try to excite it. We call this like equilibrium state. Keeping the patient inside the magnet for infinity will not benefit us. Aligning the protons will not generate a signal unless we try to excite it. So to excite this is we call it equilibrium state or the normal state. When you put the patient, half of the protons will align with the magnetic field, the other half will align parallel to the magnetic field. There will be a little small excess of proton in the direction of the main magnetic field. So the idea now is to move those small excess. When I say small excess, means 1 per million. For example, if you have 1 million protons, there will be 1 million with the magnetic field, another 1 million in the other direction. But with the magnetic field, there will be 1 extra. So 1 plus million, and then 1 million in the other direction. So our body full of hydrogen, so millions of protons. So the number of protons that is excess, the extra number of protons will generate something called magnetization. And this is the source of the MR. So the idea now is to make that proton moves from the direction of the main magnetic field to the other direction, to the opposite direction, and leave it to return or relax. Once it's relaxing, it will generate a signal. That signal, we will pick it as the MR signal. So this is the situation when the patient inside the magnet, the protons the net magnetization, they are all aligned with the main magnetic field. Now we will try to take them away from the magnet. We expose them to an external magnetic field, or what we call radio frequency waves. So they will start to move away from the main magnet. Then we will turn that external energy. So the proton now, they will just relax and go back to the original location, which is in the main direction of the main magnetic field. So releasing of that energy will be varying from tissue to tissue in our body. For example, in the brain, white matter will act different than gray matter, than CSF. So each tissue will react differently, and then that will be reflected in the image brightness or darkness. So the rule of that external RF energy is to take the protons away from the main magnetic field. So for example, we call this is 90-degree RF pulse, means the energy given, it's enough to take the protons 90 degrees away from the main direction of the main magnetic field. And then we just turn it off and just see what it will do. See the reaction. So this is exactly what is happening. So we just apply an energy. The protons, they will take that energy and start. While they are persisting, they will just release the energy and go back to the original location. Now let us imagine the protons that are in the transverse plane. So they will start to persist in the transverse plane. We agreed that this is like a small magnet. Moving a small magnet inside electric coil will generate electricity. So that electricity can be measured, and this is what we call MR signal. So that's the protons now, they are spinning across an antenna or RF coil. That will generate an RF signal. This is what we call MR signal that we generate and then translate this to image. So the generation of that signal in that coil will generate a decaying signal. We call it FID, free induction decay, because it starts with high signal and diminish until it gets to zero. If we ask any mathematician, what is this? He said, this is an exponential curve, and this can be expressed in a constant of decay, which we call it a relaxation time. We will see it So we have two relaxations. So the response of the protons to an external energy will be expressed as a transit change, and then it will release that energy. The release of energy will be expressed as two relaxations. So first, they will dephase, as we can see. Once the external RF energy is removed, protons release the energy in a process called relaxation. So as you can see, they will start to distribute or dephase. At the same time, they will go back to the original location, which is the main magnetic field direction. So this relaxation is caused by two interactions, spin-spin and spin surrounding. So we call them T2 and T1. The cause of these, why the protons, they release the energy, why they lose the energy, because the protons, once they are in the z-axis, in the main direction of the main magnet, they will be exposed to the main magnet itself, and the difference between them will not be seen. But once they are away from the main magnetic field, the difference will start to appear. Some protons are, for example, in the fat, some in the protein, some in the... So according to the local magnetic field of the proton, will spin in different speed. And then they will start with one group, but by the time they will start to, as you can see, immediately there will be one group, and then two groups, four. That will increase by the time, and that will cause what we call T2 relaxation. So T2 relaxation mostly happens in the transverse plane. This is one of the causes of the relaxation. This is if we are looking from up to the protons, as you can see, and this is the component the main component of the protons. That component will start to decrease by the time, because the variation between the protons will start to increase, and the total signal finally will be zero. Again, as I said, if we draw a curve, so immediately after we flip the protons, the signal will be maximum. So by the time that signal will be decreased until eventually will be zero. And this is a comparison between if we have two curves, two tissues, each tissue will act differently. And for example, we have fat, gray matter, white matter, CSF. Each one will have different response, different relaxation. Computer will only understand values, so I cannot give curve to computer. We have to translate this to values, so we agreed to describe this by constant. So we say the constant of decay is T2 value. So as I said, different tissue has different relaxation time, and this is what so for example, if I look at the signal at this point, we still see both tissues signal. But let us see, for example, after some time, this signal will appear black because it's canceling itself. So each proton, it will have another proton in the other direction. So the total signal will be zero. So that will appear black in the image. While this still have some signal, so it will appear bright in the image. So that's example. What I said, if we pick the signal at this point, you can see everything's bright because they're still intact. They still have net magnetization. But as we go with the time, if we increase the capture time, let us say, or echo time, and that will be described later on. If we increase this time to 80 milliseconds, you can see some tissues become dark because they already dephased. They already lost the signal. While we still have maintained some tissues that have very slow decay. Okay. The other cause of relaxation is called T1 relaxation. And this causes the protons to go back to the original location, which is the main magnetic field direction. And as we can see from there, this is the RF excitation. It turned off. Now it will return back to the original. But remember that it will not return as a group. It will return as every proton will have different route of recovery. So this is an example. This is, let's see if I can just pause this. Yes. Pause. So the way that the proton they recover, again, it follows different exponential curve. So different tissue in our body will follow different way of recovery. And that is also expressed as a T1 relaxation. So we have a T1 relaxation for the liver, T1 relaxation for the spleen, a T1 relaxation for the kidneys, for example. So each tissue have different T1 relaxation. This is an example of some tissues in the brain with their T1 and T2 values. As you can see, that some of them has 67 milliseconds, which means that dephase fast, and some of them, they take more time to dephase. So that's an example. This can be translated to a contrast, can be translated to brightness and darkness in the image. So each tissue has a T1 value and has a T2 value. So this can be translated to bright or dark in the images. That will be, again, as T1 images, T2 images. All this can be described later on. So this is an example of an images. The third parameter that describes the MR signal is the proton density, which is similar to what we have in CT with Hounsfield number. So each tissue has different number of protons in it. So that will be reflected also in the images. If we have a tissue with no protons, like a bone, for example, that will appear black because it has zero signal, regardless of T1 and T2. While if we have a tissue like a CSF, it has a lot of protons, and that again will add to the signal. But the final signal will be controlled by mix of all, T1, T2, and proton density. So what we see is like a mixture of all of these variables. Again, this is an example of a T1 of the fat, which is 150 milliseconds, and the T2 is almost similar to the T1, which is exception of the fat, which it's recover fast and dephase fast. But compared to the CSF, as we can see, it takes very, very long time to recover. So after we turn it to the transverse, it takes like 2 seconds to return. And it takes more time also to dephase. That's why fluid always appear bright in T2 images. Now we understand the signal itself, how it is created, how it's captured. But again, this is signal. If I receive signals, that doesn't mean I have image. So for example, if I put a patient inside and then I pick the signal from the brain, it says that signal is not normal. That is not a normal T1. But where is that lesion? Is it in the right side, left side of the brain? Is it in the pituitary or in the... So we have to translate this to images. So to be able to do that, we have to give a label for each signal. So those signals which is emitting from the patient has to be linked with their original location. So this is achieved by what we call in MRI, it's a gradient, and that is giving a code for each signal. So adding a gradient magnetic field will help us to do that. So we have 3 gradients within the magnet inside. Gradient means 3 coils, electric coils inside the magnet. Their function is to generate a magnetic field that starts from 0, for example, start to increase. It is always in the middle. It's isocenter, so this is the main magnetic field, always in the center. And for example, there, the center of the magnet will always be the original magnet, like 1.5 Tesla. It will decrease from the left and increase in the right. Similarly there, it will decrease from the bottom of the magnet and start to increase. Again, from head to foot. Let me just check something there. So this is the patient that we just described. He has, for example, just for simplicity, we have 3 protons. Those protons are emitting signal. All these signals will be translated as a single peak. Again, this is not very helpful. So if we introduce the gradient, we agreed at the beginning that the proton will increase the frequency or the speed with the magnetic field. As we increase the magnetic field, the proton will persist faster. So this proton is exposed to less magnetic field because the magnetic field there is less. So the frequency will be again less. As we increase the magnetic field, these 2 protons will be exposed to more magnetic field, meaning they will spin a little bit more faster, or they have a higher frequency. This can be translated there. That single proton has a single peak, so it's, for example, 1 amplitude and less frequency. These 2 protons has more amplitude, double the amplitude, again, and more frequency. Let's play with this more again. If I have more protons, so I have 2 protons there. Again, their amplitude is similar to this, but they are exposed to less magnetic field, so there will be less frequency. Again, if I have 3 protons in the middle, again, they have triple the amplitude of this one, and they will be less frequency than the remaining, so it will be located there. This can be applied for few protons or millions of protons. So in reality, we have millions of protons. All this will be exposed in the magnetic field, and then they'll be translated to image. So this is patient without magnetic field. It's a single peak. With introducing the extra magnetic field, which we call the gradient magnetic field, there will be like 2 peaks, as we can see, or it depends on the shape and the number of protons. So there are 3 types of image coding or labeling given to the protons, so they can be localized to their location. And those are frequency encoding, phase encoding, and slice selection. So each signal can be described by, so for example, if I have a signal, I want to describe it, I will say, for example, these 2 signals, or these 2 waves, has similar frequency, similar phase, where they start from 0, but different amplitude. This has higher amplitude than this one. Now, these 2 waves have similar amplitude, similar phase, but they have different frequency. The third one is the phase. So this has a -1 phase, means that it starts from not opposite to the antenna. It's far from the antenna, like 90 degrees. This is start from opposite to the antenna, and this is, again, clockwise positive. So they have similar amplitude, similar frequency, but different phase. So we will try to utilize this information, variation between the signals, to give a label to the waves. So imagine that we already put the patient inside. Now all the protons, they will persist with the same frequency of the magnet, which we call Larmor frequency. If this is 1 Tesla, so they will start with the 42 megahertz. What happens if I start now a gradient magnetic field? Those protons in this row, they will start, this column, they will have higher frequency than the one in the middle. The one in the middle will have, again, higher and higher. So this is applied for 3 columns, but in imaging we have like 256 or 512 columns. So each column has different frequency, and the wave, when it's picked by the magnet, by the antenna, it will know that it is coming from right side of the image or left side of the image according to the frequency that it carries. So this is an example. The right column in the image has higher frequency, so the computer will know that this is coming from the right side. This has less frequency, it's coming from the left side. So all these protons will have the similar frequency, So it's easy for the matrix, image matrix, to be translated to according to the frequency. Now, for the phase encoding, the signal is coded according to the phase shift. So now we managed to distribute the protons in columns. Now, again, this is not enough. It's a 2D image. So what about the rows? We will use the other variable, which is the phase. So we will use a phase by introducing a phase shift, for example. Now, if we apply a gradient in the other direction for a short time and then turn it off. So they start from the same point, but because this line is exposed to higher magnetic field, will acquire a shift more than the one in the middle. So at the end, we will find that each line in the image will have its own shift according to the location. So the final image that we see, in each pixel of the image, the waves coming with frequency and phase. So it can be located according to its frequency and phase. For example, this is from 0 to 10, 10 to 20, and so on. Similarly for the phase, from 0 to 10, 10 to 20. So each wave is coming with a specific frequency and phase, and it will be allocated its location. The final step is to have once we have frequency and phase, so we will put that wave. Now, the amplitude of that wave will be translated to brightness or darkness. So if we have a little amplitude, that will be black or dark. If we have higher amplitude, it will appear as bright in the images. So now we get the signal, we distribute them according to the frequency and phase, according to their location, and the brightness and darkness will be depending on the amplitude of this signal, which again depends on the T1 relaxation, T2 relaxation, and proton density. The last technique of coding, so we managed to code in the 2 dimensions, X and Y. Now, what if I want, for example, to acquire an image in the orbit or in the base of a skull, for example? I have to do something called slice selection. So slice selection, again, is achieved by applying a gradient in the third direction, which is similar phenomena. If we apply a gradient, that means those protons located at this point, after the slice, they will have higher frequency than lumbar frequency. And the one below, they have less frequency than lumbar. So when I do excitation, only those protons will be excited because they are the only one who match lumbar frequency. In the physics of MRI, that the word resonance coming from that, the antenna, as in our radio set in the car. For example, if you drive your car and then you turn the radio set, why you are only hearing one channel? Because you turn your antenna to receive or to pick that channel. Similarly now, we will tune our body to have either higher frequencies or lower frequencies. So only the one in the middle that will match the frequency of the antenna. So we can pick that signal. Now, as that gradient strength decrease or increase, we will be able to have either thin or thinner cuts. So if that gradient is shallow, for example, we will have a thinner slices. If there is no gradient at all, we will excite the whole brain. So this is what is happening. So we apply a grade in the third direction. We apply a slice selected gradient that will focus the slice, the excitation to one slice. Once we receive that slice, then we will apply frequency and phase encoding to code or to label the protons. So this is the second step in the images, where after we select the slice, we apply the phase encoding, and then finally apply the frequency encoding to label the protons. Again, slice selection is very helpful in MRI because it can allocate a slice to be, for example, axial slices, sagittal, coronal. So the gradient that is selected to be a slice selected gradient, the first gradient is called a slice selected gradient. The other two will be one used for frequency and the other for phase. I can swap between them to select sagittal, axial, coronal, or even oblique can be acquired by applying two gradients at the same time. So I can, for example, send 50% of the current to the X and 15% to the Y. By that, we will be able to acquire oblique slices. So in real scan imaging...
Sorry for disturbing, 5 minutes, please.
Okay. So the final stage of the images is that we apply this frequently. So we scan line by line method. And this is the first method introduced by Peter Mansfield. They start to scan a line by line. So they shift the phase and then acquire a line until eventually they acquire the whole lines in the images, and then the final image will be acquired and translated to image. I think we can stop at this point if there is any questions. The second part of the lecture will be about the sequences. So Peter, it's a good time to stop.
Yeah. Any question for Dr. Abdullah?
So it's either so simple or so difficult, one of them.
Any question? Raise your hand. No question.
So we can continue?
You want to continue? Yes.
Yes, good.
We will start now about MRI sequences.
I think since they're still capturing the information, it's better to hold them. So we will go directly. Now, we already know that the images is already generated. But that was the simple way of acquiring the images. We have many, many ways. And as I said, as I saw in the video there, the first MR images took like 4 hours to acquire. And it's not really practical to keep the patient inside the magnet for 4 hours to acquire an image, which is really... and nowadays, we moved from this point of start to have many, many RF sequences, many pulse sequences that are available to generate the images. It depends on the goal of that sequence. But the main goal was to reduce the scan time. If we saw the last slide, this will take a long time because we have to scan the first line and then wait for the proton to recover and then scan the second line, third line. This will take a huge time. And if we imagine that every time we have to wait, for example, 2 seconds and then start the new, it takes like more than 10 minutes or 15 minutes for acquiring only one slide. And that's not practical. So they start to introduce other kind of imaging techniques to speed up the scan. So there are many, many sequences available. So, but they fall under 3 categories. We have a spin echo, gradient echo, and we have an echo planar. So, as I said, it depends on the way how we acquire the images. Under those sequences, there are many, many sequences. It's more than hundreds of sequences. The idea behind that is that each sequence is tweaked to answer something or to highlight something in the images. For example, for the scan time, we have fast spin echo, we have single shot fast spin echo, we have echo planar, flash, FGRE, and then either we can tweak the sequences to introduce a new image contrast, to change image contrast, like what we have in FLAIR, STAIR, FACETA, MAGIC, and so on. Or to explore cell behavior, like what we have, for example, in diffusion-weighted images, perfusion, and so on. Or it can be for reducing an artifact. Artifacts is one of the challenges in MRI. And during this conference, we will have one lecture about image artifact. So reduce unwanted artifact, like what we have in propeller, which reduce motion artifact, Mars, which is reducing metallic artifact, focus is for diffusion, and so on. So the 2 major sequences are spin echo and gradient echo. So what is spin echo and the gradient echo? Spin echo rely on applying 90-degree to flip the proton in the transfers. Once they dephase, we apply another RF pulse, has double the energy of the first one to refocus the protons. The idea behind that is that giving us enough time to code this signal. If we have only 90, the dephasing will be so fast to capture. So if we apply 180 and then we generate the echo, we will have enough time to code or to label the images. This is an example of a spin echo image sequence. So it consists of 90, 180, and then the echo. So we have the three coding techniques, the one we just mentioned: slice selection, phase encoding, and frequency encoding. The other type of scan is called a gradient echo. So in a gradient echo, we replace the 180 RF pulse with using the magnetic field to refocus the proton. So the idea is to play with those protons. Those protons are small magnets. You can play with the magnets with radio frequency, or you can play with them with the magnetic field. So now we have a set of protons or set of magnets. We can flip them, we can move them with either magnetic field or radio frequency. So this is the gradient echo sequence, which based on the applying radio frequency at the beginning to flip the protons in the transverse, and then we apply a gradient magnetic field to invert the protons and refocus it. Another way of modifying this is applying a single shot fast spin. A single shot fast spin echo again can reduce scan time. The fastest ever imaging is what we call echo-planar imaging. In echo-planar, we fill the whole image by one excitation. So we excite the protons, apply a frequency, slice selection, frequency encoding, phase encoding, all in one shot. So that will be flipping the frequency encoding and phase encoding alternatively to fill the whole images. So image can be acquired in a less of a fraction of a second. That's not free. Quality will not be so good like the one we saw at the beginning, but it has its own application. As I said, why we have many sequences? Because each one has its own application. Sometimes resolution is not the main goal for us. The contrast is more important. And sometimes resolution is very important, so we concentrate on the kind of images that we want to generate. That's a spectrum of images that we usually can see in MRI. So if I for example, we have T1, T2 weighted images, and then we have a T1 with contrast, we have fluid flare. So each one of those has a different design of the sequence to highlight a specific contrast. We will try to go fast through these. This is the example of image contrast, as I said, T1, T2, proton density. In each one of those, the contrast was highlighted to show a special characteristic of tissue. For example, this is a T1 weighted images, means it's a mapping of T1 characteristic of the tissue. You remember there's some tissues, they recover fast, some they recover slow. So when you look at these images, the one with dark means they recover very slow, while the one in bright, they recover fast. So from this, we can understand that this reflects the recovery of the protons. This is the T2 weighted images. So it reflects how fast the proton they are dephasing. The bright signals, they keep intact for longer time. So after excitation, they're still holding until even more time. Sometimes even after 100 milliseconds, 200 milliseconds, you still see them. While the one with the dark is just dephasing immediately after the excitation. So they will appear dark. In the last one, the proton density, which represents the amount of protons in the tissue. So it doesn't rely on T1, neither T2. It's just focused on the amount of the proton. The one with the bright means it has higher protons. The one with the less signal intensity, it has a less proton density. So as I said, we can play with this, with the T and TR, to generate either T1 images or T2 images. And this is an example of how they appear. Usually in T1 weighted images, fat will appear bright, water will appear dark because it takes a long time to recover. New blood is bright, white matter is brighter than gray matter. Calcification is dark. Why? Because it has 0 proton density. So it is always black. احنا قلنا هي mix of characteristic, T1, T2, and proton density. If there's no protons, there's no signal. So it will appear black in the image. It is used for anatomical details, vascular changes, also contrast enhancement. That's an example of how T1 images or anatomy will appear in T1 weighted images. T2 weighted images, fat is darker than T1. Water is always bright, except blood, we will mention that. Blood in the vessel is dark. White matter is darker than gray matter. Calcification, again, is dark. As I said, there's no protons, so there's no signal. It is used for identifying lesions and cysts. And this is an example of how some pathology will show in a T2 weighted images, in edema, necrosis, for example, cellularity, and hemosiderin. Sometimes you have something bright and you don't know this is like blood or enhancement. So we give contrast to see the extent of the tumor. So T1 enhanced, which means with contrast, will show a brightness. And this is the T2. But this is already bright before contrast. So how we can tell if this is really enhancement or first, the idea of contrast is that it makes the recovery of the proton faster. When we inject the patient with contrast, it will make the protons recover fast. So they will appear brighter compared to the one without contrast. So contrast is very important in for example, metastasis, meningeal disease, and in solid component of the tumors, infection, and active inflammation, mass characteristics. All these contrast is really mandatory to have. As I said, sometimes this signal is high before even giving the contrast. So how I can tell this is mass or lesion? Because it's already bright, because it's fat. So the idea is to get rid of the fat. So we apply fat suppressed. Fat suppressed is an RF signal that targets the fat only. It will take the fat away. And after that, we will excite everything. So this is contrast. This is post-contrast without fat suppression. This is post-contrast with fat suppression. So the fat is already dark, and then you can notice if there is any enhancement. So that's the idea between water and fat. Because water is a small molecule, it will persist faster than the fat, which is a large molecule. And then if we apply an RF pulse that target the fat only, with a frequency, an antenna is tuned to target the fat only, we will be able to get rid of the fat. And then another expansion of T1 is to make it a 3D. So instead of having a slice selection, we will acquire the whole brain with a 3D acquisition. And this is an example. Because of the time, we will just go through the... this is just showing the difference between how the T1 appears in 1.5 Tesla compared to the 3 Tesla. So another modification of T2 weighted images, احنا قلنا في البداية, we modify the T1 with the contrast. Also, we can modify the T2 by suppressing the CSF signal. Sometimes there's a lesion just surrounded by the CSF, or in the, for example, white matter changes, and you cannot appreciate that because of the CSF. So we need to suppress the CSF. We apply what we call FLAIR, which is fluid attenuated inversion recovery. Again, it is an RF pulse that targets only the CSF. So the CSF will appear darker. That inversion recovery sequence can target any tissue to make it unseen in the image. For example, if I turn my inversion time to be 130 milliseconds, I will be able to suppress the fat, or gray matter, white matter, or even CSF. So by selecting a TI, I can get rid of unwanted tissue in the image. So FLAIR can be acquired in a 2D or a 3D, like in, for example, in demyelination disease, we need to see the changes of the white matter. Let's skip this, yes. So another, again, modification was we got double inversion recovery, which we can suppress 2 tissues at the same time. Not only CSF, but we can suppress the CSF and the white matter, so the changes will be more seen. Again, a T2 with the fat suppression would be important if there is a tissue surrounded by fat. So we can apply a T2 with fat suppression to reduce the signal from fat. And fat suppression is essential for some kind of diseases. The third one is stir and proton density in the spinal cord. So as you can see, with the normal T2, sometimes it's really difficult to see the lesions within the cord. So if we apply a proton density, which depends mainly on the number of protons, will be better appreciated. We did, for example, in one of our paper, we combined the proton density with the T2 to highlight, so to take the flavor of T2 and also to enhance the signal according to the proton density. So again, a fast spin echo sequence is designed to speed up the scan. So instead of acquiring line by line, we acquire 8 lines or 20 lines at the same time. That will reduce the quality of the scan, but again, it will increase the acquisition time. So this is the fast spin echo images. It's faster than the conventional spin echo. Okay. We will just skip these sequence slides. Gradient echo sequences, at the beginning, we said it's introduced at the beginning for reducing the scan time, but it also has advantage of highlighting an iron component of the blood. So a tissue with a blood like hemosiderin that make the signal decay much faster. So we use a gradient echo sequences, or what we call T2 star sequences, to highlight if the patient has a bleeding or, for example, a signal lost due to the paramagnetic or diamagnetic or calcium blood component, all will show darker in the images. This is again modified with what we call susceptibility weighted. Susceptibility weighted is like a T2 star image, but with some modification to add the phase component of the image, so to make the image more depends on the susceptibility. Susceptibility means sensitivity to component of magnets. The blood has an iron, so it will be more sensitive to that iron. Another sequence is called diffusion-weighted images, where it actually concentrates on the macroscopic movement of the protons. For example, patient with a stroke, acute brain ischemia, white matter changes. So the idea behind diffusion is that we utilize a very fast sequence. It's called echoplanar imaging. And in this sequence, we will be able to see if the protons are moving freely or they are restricted. And I have a short video for that, just to show you how this is, for example, a proton moving freely. So if we see the diffusion compared to that one, yeah, see that protons, for example, there. If they are restricted, we apply the coefficient in 2 times. We scan it the first time, and then we scan the second time. If we subtract them, if the proton is still in the same location, means it's restricted. The movement of that proton is restricted, which can be translated in the image by bright or dark. Just a quick end of the lecture. We will just, as I said, MRI never ends. So many sequences introduced from the point where Peter Mansfield introduces his first MR images to nowadays we move to the what we called single acquisition, or called quantitative MRI, which is the topic of my lecture tomorrow maybe. In the quantitative imaging, we acquire the signal and then reconstruct it according to its T1 and T2. If I can just show this slide. I don't know what is going on. So in this acquisition, it's a single acquisition, can generate T1, T2, proton density, flare, stir. So all contrasts can be generated in one acquisition, and then back reconstructing the images according to those values, T1, T2, and proton density. And then the radiologist can, it depends on the way how we acquire it, so it's multiple acquisitions at the same time. So this 5-minute scan can generate many images, contrast, and patient can go home, and then later on we will get whatever images we need. For example, we can get a T1, proton density, inversion recovery, T2, and all these are set by reconstructing the data that we acquired during the scan. I hope this was a little introduction to MRI. Sometimes we need like 2 days to describe all this information, but that's the time that's available for us to have some hints of MRI sequences and imaging.
And thank you, Dr. Abdullah, for that insightful presentation.